A Puscast, a review of the infectious disease literature. This covers the first 2 weeks of April in the year 2017. References as well as links to my growing multimedia empire are available at edgydoc.com. And if you're so interested, check out my Twitter feed, ID Factoid, where every day you get, in less than 140 characters, a piece of information from the literature. But let's move on to said literature, shall we? First up, giant viruses. I talked a while back about mimiviruses and its kin, and the hypothesis was these things were so ginormous that maybe they represented a new and fourth branch of the tree of life. An article in Science this month suggests nope. The reason they're so big is that they just took in a lot of DNA and expanded. So it would appear that these viruses have done the genetic equivalent of eating at McDonald's. Still really cool, these giant viruses, but they are just viruses, just fat viruses that need to go on a diet. We are heading into mosquito season soon, and the southern half of the United States has at least 2 mosquitoes that are very efficient spreaders of viral infections. And now we have yellow fever back in the Western Hemisphere. There's an outbreak going on in Brazil right now. And anything that's spread by mosquitoes will spread. Chikungunya, dengue, yellow fever, Zika, all coming our way. Yellow fever used to be endemic in the colonial times and caused outbreaks with all sorts of deaths. We went on a yellow fever tour of a cemetery in Philly at the last IDSA I attended there. I suspect that those viruses and a pandemic from influenza are just a matter of time. Unless when we build the wall, we impregnate it with DEET. Now there's an idea. HIV's a tricky little bugger. If you have patients coming with neurologic problems who are apparently suppressed and have good CD4 counts, in this study a little above 400, they can reactivate their HIV only in their brain. If you MR, you'll find diffuse white matter changes, and lumbar puncture will show HIV replication in the CSF, often with resistant strains of HIV. So HIV has different compartments in which it can reproduce and damage, one of them being in the CNS. They call it CSF Escape, which I think was a Kurt Russell movie. But the take home is that with neurologic problems, even when they're suppressed, you cannot rule out active HIV replication in the brain as an etiology until you do the MR and the lumbar puncture. For those of you planning to party and travel this summer, beware of Aruba. They are having spread of resistant HIV in that island country. And half of patients who are newly diagnosed with HIV have an HIV that is resistant to NNRTIs. They all have the K103N, mellow jazz for your listening pleasure, the K103N resistance mutation. And so they are all failing their first-line NNRTI therapy, resistant, and spreading the virus. And I'm sure it will spread out of Aruba too. Coughing, sex, and mosquitoes are the 3 best way to spread infections. And in case you were wondering, 42.5% of Americans are infected with genital HPV and 7% with oral HPV, the prevalence being higher in men than women. And these are conservative estimates, the data evidently having been generated at the Republican National Convention. No, that's not what a conservative estimate is. So more people probably have HPV, especially in high-risk populations, than this would suggest. I increasingly am intrigued about the idea of the total body condom that was worn in Naked Gun. It would probably stop mosquitoes as well. And if you're interested in where your state stands with syphilis, the CDC has state-by-state specific rates for both men who have sex with men and men who have sex with women. And it's generally speaking the conservative South that has all the syphilis. both in men who have sex with men and in men who have sex only with women. The states that lead the list are Louisiana, Mississippi, North Carolina, and South Carolina, all firmly in the Trump camp. The liberal atheist states tend not to have as much syphilis. I'll let you draw whatever conclusion you want. And if you want to send me hate mail, it's mcrislip@mac.com. With the caveat that it may be read and include your email address. There is this post-infectious disease state that is the final common pathway from a lot of infections: Lyme, Rift Valley fever, and Q fever. The question was whether or not doxycycline long-term would help with a fatigue state, and when compared to placebo, the answer was no. They also included in this trial patients who got cognitive behavioral therapy, and they found some difference. Fatigue severity was significantly lower after CBT than after placebo, difference 6.2, p.03. I will say that after all my time reading alternative medicine papers, I would probably call that negative. With 50 people in each group, a p of 0.03 is probably garbage. And I'm increasingly convinced that statistically significant should be at least 0.005, especially if you factor in prior plausibility analyses of clinical trials. And the difference of 6 is hardly likely to be clinically relevant. They say in their conclusion the outcome is clinically relevant, but they don't specify how, especially since it's more likely to be a false positive. But it's a general rule of thumb that any clinical trial's results will be much overhyped in terms of the results. So color me unimpressed. I wonder which color in the Crayola box is unimpressed. More on Cipro is a bad drug, in terms of side effects, that is. Quinolones are associated with torsades, retinal detachment, aortic aneurysm rupture, tendon rupture, C. difficile, and MRSA. And now we can add an increased risk of eardrum perforation from quinolone eardrops after placement of tympanostomy tubes, a risk that goes up even more if you add steroids to the mix. What all these side effects have in common is the quinolones mess with healing. Quinolones are still great at curing infections, but they certainly have downsides for side effects, and I certainly try and avoid them if I have to go longer than a couple of days. Is more necessarily better? With beer and ice cream? Yes. With time off? Yes. With antibiotics? Well, maybe with daptomycin. I find the information for treating staph that you should push your daptomycin probably closer to the 10 milligram per kilogram dose than the usual 4 or 6 that shows up on the computer-generated lab order sheet in Epic. And higher doses appear to be more efficacious for VRE as well. For death, which is one of those hard endpoints, treating vancomycin-resistant bloodstream infections with daptomycin had the best outcomes if you gave greater than 9 milligrams per kilogram, intermediate outcomes if you were between 7 and 9, and the worst outcomes if you were under 7 milligrams per kilogram. For anything but probably the most trivial soft tissue infection with an allergy to more inexpensive agents, daptomycin should be given at 9-10 milligrams per kilogram. And for the record, the makers of daptomycin have never given me a penny. Though if you're listening, if you'd like to send me a big fat check, I'd take it. Treatment of BV, bacterial vaginosis, is not a primary literature that I'm acquainted with. So when I read a meta-analysis, I don't really have a good understanding of the background literature, and I'm disinclined to look it up. Sometimes when you look at the primary literature, the meta-analysis is where you take a bunch of cow pies, put them together, and declare it is now gold, when in fact all you have is a large cow pie. This study looked at whether or not probiotics added anything to metronidazole in the treatment of bacterial vaginosis, and the answer was no. And that really doesn't surprise me because the bacteria found in probiotics are not normal flora. And there is a bit of an anatomical disconnect that would lead one to think that oral probiotics may not reach their site of action. So, most cases of lower extremity cellulitis, diffuse erythroderma, is due to group A strep, which is quite the toxin producer. Would adding clindamycin to a beta-lactam benefit in the treatment of cellulitis? Well, unfortunately, it turns out the answer is no. In this study out of England, patients with diffuse erythroderma, cellulitis, were enrolled in a double-blind randomized trial between flucloxacillin plus or minus placebo or clindamycin, and there was no difference in outcome. Well, that's not entirely true. Those in the clindamycin group had twice the diarrhea. I've always been a fan of ameliorating the symptoms of infectious diseases by screwing with bacterial virulence factors. It works with necrotizing fasciitis due to group A strep, but not with a simple cellulitis. Bummer. It's depressing how often a great idea gets killed by reality. I have said before that if I were a superhero, Staph aureus would be my arch enemy, my bête noire, to be a little more hoity-toity. In the comic books, the arch enemy always dies, only to come back stronger and harder to kill, and that's Staph. One always struggles with Staph bacteremia and trying to figure out if there's endocarditis or not, often erring on the side of over-treating what isn't there rather than not treating what is there. You can add high vancomycin MICs to the list of issues to fret about with catheter-related Staph bacteremia. And in this study, as the MIC to vancomycin went up, so did endocarditis as a complication of catheter bloodstream infection, at almost double the rate of low MICs to vancomycin. And vancomycin resistance does affect the efficacy of other antibiotics, again depending on the model in the study. Yet another thing to fret about. Generally speaking, if you don't grow MRSA, the patient doesn't have MRSA. Patients in the hospital often get started on vancomycin plus the beta-lactam du jour when patients are septic or have ventilator-associated pneumonia. If you don't grow out an MRSA from the sputum, and in this study, if you have a negative nasal swab for MRSA, you don't need to treat for MRSA pneumonia. So you can stop your antibiotics a lot sooner. In this study, 48 hours sooner. Although it is remarkable how often people don't pay attention to negative cultures and continue the antibiotics. Generally speaking, prophylactic antibiotics only work to prevent surgical wound infections. And there, I'm actually not so certain anymore. The old studies showed benefit, but the old studies were done in the era when we were so sloppy with all other aspects of surgical wound prevention. Many studies, if you go back and look at the numbers from the old days, show people went from a horrible SSI rate to a less horrible SSI rate by switching a given antibiotic. I suspect, but don't know, that if you do all the hand hygiene, etc., well, that parenteral antibiotics probably add very little to surgical prophylaxis, and antibiotics add nothing to any other prophylaxis. I tend to think that antibiotics are a surrogate intervention when the rest of your practice sucks. This study, not quite relevant to my earlier rant, had to do with airway colonization of Staph aureus and whether or not it could be eradicated with antibiotics, and it can't. And it doesn't prevent ventilator-associated pneumonia. I am not surprised. Antibiotics are never the solution to issues that are fundamentally anatomical and practice-based. I mean, in an 8-month period in this study, they had 16 VAPs. That's 2 a month. We get 1 a year, tops, at my hospitals. And that's following the CDC definition. I see 2 a month and I wonder, what the hell is your problem? But I'm not surprised that the answer to the problem is not antibiotics. I like to harp on the non-infectious complications of important infectious diseases and how patients who get infected have mortality increases from a variety of usually cardiovascular events. This study found that getting pneumonia increased your risk of developing heart failure down the pike. And if you got pneumonia, your risk in the next 10 years of going into heart failure was 12% when compared to matched controls. And the effect is most marked in the first 5 years after pneumonia. I wouldn't be surprised if other infections have a similar problem, at least infections that require hospitalization. The inflammatory response, or as the wackaloons like to call it, boosting your immune system, is not good on the cardiovascular system and is another factor to watch for in patients who have been hospitalized for pneumonia. I wonder if I'm overtreating some of these infections. This study out of Switzerland looked at treatment and outcomes of small joint infections, mostly the metacarpal phalangeal joints and the proximal intraphalangeal joints. These patients had trauma. They done got bit because they had staph, beta strep, and pastorella. And after debridement, had 14 days of amoxicillin clavulanate, and most of them did fine. All were cured. 80% had good function. Certainly, I always recommend aggressive debridement of any undrained pus. It's all about the source control, but I was surprised to see that Augmentin for 2 weeks was sufficient to cure. I have always gone a couple of weeks of IV therapy, especially in the hand, because a little bit of trauma leads to long-term disability, which they didn't have. So maybe I'm way over-treating these, with all the caveats of a retrospective case series rather than a prospective randomized trial. And another what the hell study out of the American Journal of Medicine. It's called Errors in Diagnosis of Spinal Epidural Abscesses in the Era of Electronic Health Records. And they found that about half of their epidural abscesses were screwed up, with up to a 12-day delay in diagnosis versus 4 days in those that had the diagnosis made promptly. The times I've been burned on epidural abscesses are when the patient had no localizing symptoms, so why would you suspect it? And I always fret about staph bacteremias on ventilators who are paralyzed and sedated, fretting that they have an epidural brewing that they can't give complaints about. But the reasons for failure to diagnosis were the following problems that were not evaluated, one of which focal neurologic deficits with progressive or disabling symptoms. Who the hell sits on that for 12 days? The other two common red flags that were not evaluated were unexplained fever. If that was the only symptom, I'd be disinclined to do a spinal MRI, and active infection. Fever, back pain equals MR. Back pain, bacteremia equals MR. Progressive back pain with or without focal neurologic symptoms equals MR. My problem is we get too many MRs that are negative. You gotta wonder what's going on in this VA hospital. And I had to laugh when they said in the abstract that despite wide availability of clinical data, that's the great thing about the electronic medical record. Just because it's there doesn't mean you can find it and look at it. I see a ventricular peritoneal shunt infection maybe once a decade. Just don't have a lot of them in my particular hospital. This study looked at all of their VP shunt infections over a 34-year period, a time frame of which many things changed, but the important thing was the following sentence. The only independent risk factor that predicted failure was retention of the VP shunt, regardless of the strategy. You often get positive herpes cultures such as HSV, herpes simplex, and CMV in severely ill ICU patients. This meta-analysis looked at 22 different studies on CMV in the ICU and found that it is a bad thing. It increased ICU mortality, odds ratio 2.55, overall mortality 2.02, duration of ventilation 6.6 days, nosocomial infection 3.2, need for RRT 2.37, and ICU stay 8.18 days. Yet, despite all this, we don't know if this is a marker of severity, reactivation because you're sicker than stink, or is this causal to the worse outcomes? Boy, with all that, you almost want to start these patients who are positive on valganciclovir, despite its cost and potential toxicities. But what we really need is a clinical trial to determine if intervention improves outcomes. It's about time, as these first studies that I remember were probably 10, 15 years old. If someone can generate a whole bunch of vitamin C treatments, certainly someone can generate an equally crappy study using valganciclovir. Some data would be better than none. Well, maybe not. By the way, if you're interested in an extended rant on vitamin C and ICU sepsis, I wrote a blog entry for that over at Science-Based Medicine. It's also a Quackcast if you don't listen to that wonderful podcast of mine. But given the morbidity CMV causes in so many other populations, boy, it's hard to believe it's not causing morbidity in the ICU as well. But then belief is what you do when you don't have data. And cholera goes up when it's warm and wet. No big surprise there. El Niños lead to cholera. Warm, wet weather leads to all sorts of infectious diseases. Add cholera to the list. Between climate change and increasing mosquito populations and the anti-vaccine movement, I have a real opportunity to see all sorts of infections that I thought I would never get to see. But here's hoping I never see cholera or measles. And that brings us to the end of this Puscast for April 1 through 15 in the year 2017. References are available at edgydoc.com, where you can find links to my growing multimedia empire of books, apps, blogs, and podcasts, because the world needs more Mark Crislip. Otherwise, as always, thank you for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation, goodbye.